All right, so we can go ahead and begin. Hello, everyone. Welcome to today's shadowing session. Today we have Dr. Sarah Ramzan, and she's a family physician. So thank you so much for joining us.
Yeah, thank you so much for having me. I work as a family doctor, and I'm really excited to have you guys here to chat a bit. I'm going to try to keep an eye on questions as well too, so I'll try to answer them as they come. But if not, I'll try to answer them at the end as well. So this is a little bit about myself. So I actually live in Toronto in Canada. And the picture that you see on the right, this is actually in Alberta in Canada when we were allowed to travel, of course. I did my bachelor's degree in biochemistry, and then I went to the University of Ottawa. I did both my undergrad and my medical school at the University of Ottawa in Canada. And then I did my residency in family medicine, and CCFP is just like the designation that you get when you complete your from the Canadian College of Family Physicians. And I love traveling, and I speak 3 different languages. And I'm going to see if I can try to answer your questions as I kind of go. Someone's asking about whether I ever considered doing plastic surgery. I'm going to get into why I chose family medicine in particular. And a good question about balancing work-life balance. Great question as well too. Yeah, okay, great. You guys are some good questions. Okay. I'm definitely going to be talking about family medicine quite a bit, so you'll probably hear a lot about that part as well. And I do touch about cosmetic injections and stuff too. So this is basically my medical journey. I did 4 years of undergrad, that's in biochemistry, 4 years of medical school, and then the residency program of family medicine is 2 years in Canada. I know in the States it's 3 years. So it's about 10 years of your life. And I've been practicing for the past 6 years. So it kind of ages me a little bit. But I know that it's sort of daunting when you're just going into things, but you realize that time kind of just goes quite fast. So in terms of why I chose family medicine, I knew I always wanted to be a doctor. And this was like back in high school when we had biology class. I remember dissecting a fetal pig, and I thought like it was super cool. And I just saw everyone else not as keen on doing it. So that's kind of how I knew that I was sort of like more meant to do this kind of thing. I thought I wanted to be a specialist. In particular, I wanted to be a pediatrician because I loved kids. And then like closer towards when I was actually in medical school, I kind of switched into dermatology as a thought process. I never considered plastic surgery just because plastic surgery you had to go through a surgical rotation, and I just never thought I was going to be. I actually was good at my surgical rotation. I just didn't think I wanted the surgeon life per se. And so I think things kind of changed for me. I think the thing that helped me the most to figure out what kind of doctor to be was I did a lot of electives. So I went around and I shadowed a whole bunch of doctors, and I realized that in some ways I kind of got a little bit bored in each specialty I did, though I don't tend to have I don't tend to get bored very easily. So I kept on like looking and looking for what I thought I would like. The reason I just didn't choose to be a pediatrician was I realized I loved kids. I just didn't love to see so many sick kids. So I went to this talk on family medicine, and they just talked about how many options there are with family medicine. So you can do, as I do, cosmetics, but you can work as an emergency doctor. You can do anesthesiology. You can deliver babies. Some people do like pain clinics. So there's palliative care, so it's end of life care. There's just an endless amount of things that you sort of can do. And there's a lot of flexibility in terms of like, do you want to work in a hospital setting? You can be a hospitalist. So basically you see relatively sick patients, but not the super sick patients who are admitted to the hospital, and you're sort of their doctor for the week or whatever that you're on at the hospital. So there's just like, I feel like a lot of options in terms of like what you can do. And I like the fact that you get to see kids and adults. And I just didn't have a lot of exposure to like even the elderly until I was sort of doing my rotations. And I realized, you know what, I kind of like them. They tell cool stories, and it wasn't just the fact that I love kids. And I like preventative medicine. So it's like trying to deal with things before they actually become an issue. So, screening, like doing like mammograms and for breast cancer, cervical cancer screening, that's like pap tests, and also just like, people who have issues with obesity and high blood pressure, like how do you give them medical advice so that they don't actually end up having long-term sort of problems. And the thing I like about it is you get to really know your patient. So I think, again, my advice would be that, if you're pre-med, I wouldn't even try to figure out what kind of doctor you want to be. You can have an idea. Like I thought this is what I wanted to do, but my best advice would be to go in with a completely open mind, because you're kind of surprised as to what you're going to pick. I didn't want to be a specialist. I thought it'd be harder to know a lot about a lot of things. It'd be easier to know a lot about one specific thing. But I just grew into loving family medicine, and you get to like develop a real relationship with your patients. You get to know them over time. So now that I've been in practice for 6 years, like I can recognize most names and I know who this person is. So I think I kind of answered some of that question is, yeah. Okay, yeah. Okay, cool. I think the rest of the questions I see here are probably things I'm going to answer anyways. So I will talk about it. I know sometimes people like me to just sort of comment very quickly on how it's different practicing in Canada versus the US. We have a universal healthcare system. So basically, we say that, our healthcare is free, but it's not really free. It's just the fact that we pay higher taxes, and it just means that we our patients don't have to necessarily pay for tests. And so as a result, I'm not really worried about if someone has insurance or not, like can they afford certain things. I just can sort of like focus on the medicine part, which I think is really nice. And I work in a low socioeconomic area. And so for me, it's really important that, I can, treat my patients and give them, the best that I can offer them. I mean, it's not perfect. Definitely like certain medications will be covered and certain won't be. But as an overall thing, I'm really just happy that I don't have to focus a lot on like running after insurance and stuff like that, which I know is a lot more common in the US. So in terms of people asking me, like, what does my week look like? So my weekend during COVID is quite different than what it used to be prior to COVID. So I mostly do a lot of virtual phone calls, which have for some people, it's really helpful. People who work, it's really nice for them. They don't. Some of my patients would have to take a whole day off just to come and see me. So in this way, we can do our quick call and they can go back to work. They can take a small break, and so that's quite helpful. Sometimes people just need a blood work requisition. Some people just need a renewal of their medication. That's pretty easy. It's when people come in with like have issues with rashes, or they have things that they want to specifically show me. I have a lot of people who don't speak English very well, so sometimes communicating on the phone is quite difficult. So I find those are, I think, the bigger challenges in terms of like working during this pandemic time. I usually come in like 1 to 2 times a week. Usually Thursdays I'll come in to do the cosmetic injections, and then Friday I'm doing seeing patients in person. In Canada, we're still kind of in actually a lockdown position, so we're really trying to limit how many people we actually see. I do some virtual consultations on Monday related to the cosmetic clinics. So if someone asked me about timing wise, like how much do I spread it out? I do 3 days at the family practice, and about like a 1 to 2 days, one specifically in person and one sort of like remotely relating to the cosmetic practice. Do a lot of people in family medicine go into this? I don't know if it's like a huge amount. I just, when I was doing my residency, I worked with a doctor who did cosmetic injections, and that's sort of how my interest sort of started. I ended up doing a course and sort of continuing from there. The other thing that's nice about being a family doctor is you can kind of work as little or as much as you want. I have a relatively big practice, so I actually take care of about 1,600 patients on top of being a medical director and doing cosmetic injections. And I would say that's a relatively big practice. I know some of my friends who have a little bit of a better work-life balance, in the sense that, they have kids and family that they are sort of trying to manage or spend more time with, I should say. They have the ability to work a little bit less. I'm kind of at the point where I've worked as little as 3 days, and I've worked as much as 6 days. And, eventually you sort of get a little bit of empathy drain. So you just get kind of drained by having to talk to people about their problems every single day. So sometimes I find 4 days is probably the ideal time in terms of like days to work if you had a possibility. I do check blood tests and stuff on weekends, and sometimes I just take it off, but at the end of the day, test results are kind of coming in the background. So I think we talked a little bit about this. So obviously not seeing patients is a little bit of a challenge, but I like the fact that I can renew a lot of stuff, directly from my computer. This basically, if anyone has COVID-like symptoms, we just tell them that, I'll talk to them and we tell them that they either have to go to a testing center or the Emerge. I've really, in talking to people for over a year now, I've maybe had like 2 or 3 patients that I kind of didn't like the story that they were telling me, and I told them to go to the hospital. And I think they turned out to be things that were relatively important to be sent to the hospital. I usually will talk to someone first, and if I need to, then ask them to sort of come in to see me if I need to see them. But ultimately we're gowned, and you have full PPE, and we screen everyone at the door. So, really trying to limit how much we're doing. So I'm asking about doing differences between doing cosmetic injections by a family doctor and a plastic surgeon. So, I mean, there are certain areas in the face that are a little bit more challenging, have a little bit higher risks of having complications. I think those are the areas that I'd probably have a plastic surgeon do. I also, when I do cosmetic injections, they're all non-surgical procedures, which means they're mostly Botox fillers or some other stuff. Whereas plastic surgeons will also do more surgical. Their prime thing is actually not just that, but is to do a lot of surgical procedures, for example, like tummy tucks or like breast augmentation or reductions, stuff that would actually require going underneath the knife, which is none of that stuff do I do. I'd have to do extra training for that, and I'd have to go become a plastic surgeon to do that. And not really, I think my interest level or where I wanted to go. So I think it works perfectly for me. But if that's an interest level for whoever it is, and I think obviously something that I would consider doing. This is what my schedule looked like pre-COVID. So I would book patients usually like 9 to 12 in the morning, and then take a break off for lunch, and then see patients between 1 and 4. So it doesn't seem like that busy of a day, but a lot of times during lunchtime, I kind of work through most of my lunch, and we'll check labs and do stuff. And on average, I see about 24 to 30 people a day. So it's about 10 to 15 minutes a person. You see some people who work in walk-in clinics where they can see up to 80 people a day. I don't know if it's very good medicine. I think you're just rushing through people. I'm a little bit different in that I have a practice that I'm sort of, worried not only about the problem that people have, but I'm also doing some preventative stuff. So I'll actually deal with more than one issue at a time. And the way I'm paid is sort of compensated for that. So it kind of works to my benefit. A lot of stuff I see a lot of babies, I see a lot of pregnant people. Diabetes and high blood pressure is like my bread and butter every day, constantly, and a lot of mental health. So those are probably the most common things that I see. So just in terms of like what I would kind of see, like I have a 50-year-old patient who's got diabetes, and he sugars are really high, his cholesterol's really high. He's had multiple amputations of his different like fingers and toes because of diabetes. And he's on insulin, but he just doesn't take it very often, or doesn't take it very well. And so he ends up in and out of the hospital. And it's one of the things that's really frustrating is you know that you could probably help this person, but they just aren't really that keen on sort of following through. I have a 25-year-old patient who's got a borderline personality. So she's got that, and amongst other things, she's, quite obese, and she's got probably like 10 different specialists that see her. And, I talk to her probably every 3 to 4 weeks, and she's got a different issue every 3 to 4 weeks. So can be kind of a bit exhausting. A borderline personality tend to be people who will create a little bit more of a stronger response to different issues. So, she sort of presents with like a little bit of a dramatic nature in some sort of things, and can be quite demanding. So, now I've known her for so many years, we kind of have a much better relationship, and I know how to manage that, but it was quite challenging in the beginning. One of my favorites is one of my patients who came in, and he had just had a heart attack, and like a couple months before that, and he told me he had like a wiggle in his leg. And then this is a Jamaican patient, so it's common for them to sort of express or explain things in a little bit of a different way. I thought he had like a nerve problem, because usually when patients describe kind of wiggle, it's usually like a nerve kind of sensation, like a burning or like a shooting type of sensation. Well, anyways, I checked his leg and had a Band-Aid on it, and when I opened the Band-Aid, there was actually a little hole and like a little something staring at me. It turned out to be a maggot, which I then took out of his leg. And I'm freaking out because, he just had a heart attack. He's diabetic. I'm worried about him not being able to get better really fast. And I told him he had to go see a specialist. And he was like, no, man, it's okay. Like the specialist is too far away. Specialist about 15 minutes away from where my office is. So I was like, okay, well, if you're not going to go see someone, then at least come back to see me. He came to see me a couple of days later, and because maggots actually get rid of dead skin, his leg actually looked okay, but not before giving me a heart attack in the meantime. And I think my 101-year-old patient, I think he's my oldest patient, but I haven't seen him during COVID, but he used to line dance every week, and he's pretty healthy. There's not really much to do, so we just see him. I talk to him about life and stuff, and he can't hear very well, so we just yell at him, which sounds kind of loud, but other than that, he's pretty cool. So it's kind of like a wide range of things that I see. If people ask me about what I don't like about medicine, I just definitely paperwork. Everyone who works at a family doctor probably can see that, when you order a test, you're not responsible for the test, and you don't get paid, and there's no time specifically set for it. So you're kind of doing that on your own time. And so that can be sometimes a bit draining. Insurance forms, people need like time off work, sick forms, that kind of stuff. So it just takes up a lot of your time. A lot of specialists or a lot of people in the emergency doctors will just say, well, go see your family doctor. So sometimes you get kind of like stuck with a lot of, problems that other doctors, they feel out of their level of expertise. So you're kind of like stuck with a lot of problems, which sometimes can be kind of a bit annoying. Sometimes you're kind of a referologist. It's a made up word, but you just, the patient calls you just because they want to see a specific specialist, and they don't, even if you know that you can treat the problem, they're still wondering like if they can get referred. Obviously, like, my training is, is a much smaller residency. In terms of us getting paid less, I mean, actually, it's not always true. I mean, some family doctors actually do a wide range of different things. For example, I do cosmetics, but like I said, working in the emerge or other sort of areas of specialty, and some of them are actually work quite a bit and actually can make quite a bit as well too. Not that I would make decisions, purely based on that, because I think for me, a work-life balance is probably important. You're not going to make more than a surgeon who's doing like very complicated surgeries, but I mean, probably for good reason, because they also went through many more years of training. So I think that's completely fair that they do, right? Sometimes you get a bit of challenging patients, as I kind of referred to. Some days it's mentally draining, and doing 5 days of family medicine, I think, can be kind of a lot, like I said. So I got a couple of questions about you guys asking about cosmetic injections. So, I started it just because my current practice had, space for me 3 days a week. And I also wanted to do something with my hands. I actually, like I said, I did well in my surgical rotations in both medical school and residency. But I just knew I didn't want to like just do that. And kind of go through that sort of like lifestyle. So I kind of found I liked aesthetics, and so I kind of took a course and found a job there. And I, like I said, mostly do non-cosmetic stuff, non-surgical cosmetic stuff. So Botox fillers, other procedures as well, PRP and non-surgical butt lifts. And I like it because it's very different. Like I work in a very low socioeconomic area, and I do sort of like this area. And I feel like it's, you can kind of get it. Like what I love doing is actually treating people who are kind of noticing the signs of aging, but not to like change exactly who they are, and I want them to kind of look the same as what they are. And so just giving them kind of like a nice sort of like, they call it a soft lift, which is like an improvement in how they look without sort of like changing their overall kind of aesthetic look. So let me just see if I have any questions that were more related to aesthetics. I think I answered questions about that Yeah, I don't really see very much overlap between cosmetics as cosmetics and family medicine. For me, there are like two separate areas of things that I do. I don't have really any overlap in people that come and see me for both, which I kind of like, to be honest. So like when I'm on one job, I'm kind of just focused on that. I'm not really sort of worried on the other sense. I mean, in terms of like anyone talking about work-life balance, I just find that you just have to make time for things that you like. So at the end of the day, like for me, I know that I could work less if I needed to, if I wanted to just do more things. I think during the pandemic, I've just been working more too, because there's nowhere to go, nowhere to travel. But you definitely can have a work-life balance. And I think family medicine probably is one of the best to be able to do both of those things. Someone asked me about like the hardest issue I've had to help a family deal with. I would say probably like the death of someone who. So I remember having a mom. I mean, mom and son are my patient. The mom is like in her 80s. The son is like 40, and he ended up having cancer. And just watching, sort of like, the mom just wasn't accepting of the fact that he had cancer, and just sort of like going through that motion. And when he did pass away, just because she was my patient as well too, as was he, and just the dynamics around all of that was a little bit disheartening. I mean, it's been now I think a year and a half since he's passed away, so she's doing a lot better and everything, but just I think dealing with probably cancer, death, that kind of thing is probably difficult. Also, I'd say having to deal with like a stillborn. I had a patient who had a stillborn as well too. I met her after she had, so it's a baby that dies after birth. So like when the baby's delivered, the baby is not alive. So those things they're sort of like very emotional things. So I think those are kind of really hard. So I think I answered cosmetic practice, the balance between the two things. Yeah, cosmetic stuff, I think I fell a little bit into fluke about that. Does one have to study longer to do one pathway in family medicine? Oh, so I mean, if you want to specialize, for example, and didn't talk about, it's a good question, like to do family medicine, but also do emergency medicine. Like in Canada, we actually have like a year fellowship, like a further training that you can do. That's usually an extra year, so that you gain a little bit more the skill set, so that you would be able to be working in the emergency. Because obviously if you work as an emergency doctor and you were trained to do like a full emergency medicine residency, that's a 5-year residency. So obviously doing 5 years emergency residency versus doing 2 years of family medicine would be kind of different. So you have to do some training to sort of improve your level of mostly the high level stuff that's really related to emergencies, which you wouldn't see which we don't see that often as a family medicine, as working as a family doctor. So quick question about what other specialties and physicians do you work with? So I work in a practice of all family doctors. I mean, the specialties, we don't have any specialists in our clinic, but I refer to specialists on a daily basis. So I have to deal with every single specialist that exists out there. So, when they send you back a letter in terms of, what happened to the patient, I find it very interesting because you learn a lot of information from that. What was my hardest or least favorite treatment or operation? Those are good questions. I thought one of the coolest things I saw was actually during plastic surgery rotation, which was someone who had gotten into an accident, and they were there was two, but one of the one I really liked was a breast reconstruction for someone who had breast cancer. And what they did was they actually took like a muscle in the back of someone's back essentially, and they took it and they rotated it around and helped with the reconstruction at the front, which I thought was such a cool thing, because the nerves and the blood supply was all sort of connected. So I just thought that was really cool. Some surgical stuff where you have to like go into the face, that's a little bit, it's interesting. Definitely, trips you up a little bit, but I feel like I was kind of I don't think it really bothers me. I think my least favorite thing, but it's like I have a love-hate relationship with this, is draining abscesses. So abscess is just like a collection of like pus and bacteria. And, there's some satisfaction when you open it, you get a pus coming out. So, and, the thing is, it's such a relief for the patient because they're in a lot of pain. And when you get rid of the pus, or you open and sort of release that, there's just like this like immense amount of like a release of pressure, but it smells like rotten eggs. So you have to have, it's the only thing that kind of half makes me like makes me a bit nauseated. So I think that's probably my least, it's I love hate, because when you do it, you feel really satisfied because you did a good job, and you know that the patient will be helped out by this, but at the same time, the smell of that is not very fun. Okay, someone was asking about like what areas of family medicine are you trained? So in family medicine, training is basically, I basically see people of all ages. So you can become, like I said, you could go into different areas. When the type of practice that I sort of do is, I would call it general family medicine. So that's when you have like a family practice. You're the first person that most people see, and I'll see newborns, so literally a couple of days after babies are born, to really like all the way. Like I said, I think my oldest is a 101-year-old patient, so all ages. Did I contemplate another field? Yeah, I mean, I talked about my journey, but yeah, I didn't really think I wanted to be a family doctor kind of thing. My schedule is pretty flexible, but not flexible. So in the sense that, I'm usually booked ahead of time. But having said that, if tomorrow I was like, I need to, for an emergency, take a day off, my secretary will just cancel every patient. But then I just feel bad because now I've have all these patients that were booked to see me, and now they can't book. They either have to see someone else in my clinic or rebook to see me. So, but in terms of taking time off, I mean, if I book it ahead of time, it's not really that challenging to do. I'll try to answer a couple more later as I just kind of go through. So in terms of like things that I wish I knew, so these are just sort of, I would say, more like life advice. I just, I was a very like OCD person when I was, like, especially in high school. Like everything had to be very organized in a certain way. And so I just thought that everything always has to flow very like, from one thing to another. Like you finish undergrad, you get into medical school, you finish, you work, but the thing is, like life doesn't often work that way. People take breaks. People end up, doing like masters or going into something else. People who are in medical school, they had careers in everything. Like like they were nurses, there were paramedics, there were people who had like who were English majors. I remember we have engineers. It's just all over the place, and you just realize that at the end of the day, that everyone comes from different walks of life, and it doesn't mean that anyone's going to be less or more successful. They're definitely good and bad times. I've definitely had some points in, especially in medical school. Prior to that, I was always, though I worked really hard, I was always really successful at school. And you go into medical school, there's a lot of really smart people, and you start to question yourself, like, do you belong there? Are you smart enough to be there? And, I ended up befriending like 3 of the smartest people in my class. And so that was a bit intimidating. But what's interesting is we all found our way. One of my friends became a surgeon, and 2 of my friends went into internal medicine. And I don't think, and this is not to like boast myself, but I don't think they would do as good of a job in my role, just as I don't think I would do as good of a job in their role. I think that everyone has their own strengths. So I think for me, talking to people and being able to empathize and to be able to develop relationships with patients are probably one of my fortes. And obviously, if you work with your fortes, you probably find a niche that really works well for you. Definitely learned a lot about myself, grew a lot as a person during all this process. Definitely learned to not take things as seriously. I mean, some people have to do the opposite, where they, not taking life so seriously and then have to become. I was the opposite, way too serious about everything. And I cried when I didn't do well in a course in university. So I realized that, to make it 10 years, I would have to not be so worked up about everything. In general, doctors aren't very good with money. So I would say that, get some help in terms of like the financial aspects. what a lot of people don't know that, when you are a family doctor, you are self-employed. So when you run a practice, you're responsible for sort of everything related to that practice. So I don't own the practice, so I work for people who own the practice. So for me, that's a position that I like. It means that I can focus on just working in and focusing on the medical aspect of stuff. What we do is I just pay a percentage of what I make and give it to overhead, and overhead covers then like nurses and staff pay, all the supplies, like the rent for the location, the computers, all that kind of stuff. I think that a career in medicine is super rewarding, but it is just a lot of work. I would definitely recommend doing stuff outside of medicine. I think that's what keeps you sane, especially maintaining family and friends. Well, can't maintain friends, but like, having friends that are outside of medicine, I think is very helpful. I think they can keep you sane. Having friends in medicine is great too. I mean, but I feel like we often just talk about medicine, and sometimes you just need a break from all that. And one of the things I try to do is, which I didn't quite do before, which is to try to live life to the fullest and be sort of kind to myself. I know that a lot of times when you go through this process, it's nerve-wracking, and like, people will tell you a whole bunch of things and you kind of get lost in the whole process. And so just taking some time to see, how to make yourself happy during this process, because I know sometimes you get pushed into really awkward situations. I don't think I've been put in as many awkward situations as I have during my medical training. You do different rotations. You have to learn how to like adapt to different settings. Some doctors you work with are super nice, and sometimes you go and you work with someone and they're not helpful. They're not very nice. They sort of like kind of look down a little bit upon you. And so, you struggle sometimes wondering like, do I belong here? But the answer is you probably do belong there. That person is probably just not well equipped to be, teaching or training people. At the end of the day, I think that most people do find their way. So that's sort of like the end of what I wanted to talk about, just like briefly about a whole bunch of things. I'll try to see if I can answer questions. I did prepare a case as well too. I just wanted to see if I answer, your questions and see if you guys still want me to do the case. I'm more than happy to do that as well too. So I think someone asked me about COVID affecting my practice, which then we talked about. How do I know what injections to give people? So, I mean, obviously it's a little bit with training. It's the same thing with family medicine. When you first graduate, you're on your own. I mean, you can have any type of problem come to you. And the interesting thing about it is, especially in family medicine, I find is that if you don't know what it is, you can ask a colleague. I still have a WhatsApp group with all the people I graduated with. We share questions and things that have come out. You can always refer. You can always send people to go do like a blood test or some sort of investigation, and then have them come back, and that gives you time to sort of figure out what you want to do. For injections, a lot of Botox. If you guys are interested, Botox is sort of, I think, a little bit more of a scientific type of injection. There's certain places where you tend to normally inject patients. So for example, in the 11s areas here or in the forehead here, it's to prevent people to sort of like developing frown muscles or like raising their eyebrows too much and creating lines there. So I feel like Botox it's sort of a science, like you should be injecting the same spots for the same spots for every person essentially. When you do fillers is a little bit more of like an aesthetic, or you have to have a good eye. So you have to be able to see like where your injections are going to be helpful for patients. And I think that just comes with time and practice. Okay, some of my favorite I think I told you some of my favorite memorable cases. I mean, I think I'll never stop thinking about that maggot case. I mean, I just did not expect to see a maggot in someone's leg. That was weird. Yes, I did. Someone asked me about considering other specialties. Yes. Yeah. Preventive medicine, I think, is a really big part of family medicine. So, I mean, some family doctors actually just practice a lot of, like I said, they work in walk-ins, and walk-ins, I think, are kind of like putting out fires. So, you have a bladder infection. Great. Here's a prescription for an antibiotic. Boom. You have this problem. Okay, boom, go do this. I feel like with preventative medicine, what you're doing is you're looking at a patient as a whole, and you're sort of saying like, listen, okay, like I know you came in in for, let's say, something really simple, like you came in for a bladder infection, but I realized that, like, I just checked your blood pressure and it's high, we should follow that up. You're due for a mammogram, so here's a paper to go do this. Well, you haven't done a blood test in a while, why don't I go send you for this? So at a walk-in clinic, you're not dealing with all those issues, you're just putting out fires. So that's why I think, if you do practice in this sort of style, I feel like, yes, it takes longer, but I also feel like you do a better job at taking care of patients. Yes, someone asked me about doing Botox injections and plastic. So plastic surgeons, like I think I mentioned that too, they do surgical treatments. I don't do any surgical treatments. So injections are like when you do Botox and fillers, they're actually just needles that you give patients, whereas in plastic surgery, you would have, for example, a scalpel and you'd open someone up to do a surgical procedure. So it's a bit different. Honestly, it's a great question about, is family medicine ever repetitive? That's an excellent question, because I just thought that when I would see my family doctor, only thing I saw him for was for coughs and colds. I just thought the family doctors deal with coughs and colds. So I had a very narrow view of what family doctors do. I will tell you, it is nothing of the sort. Actually, if I get a simple thing, I'm like, wow, that was easy. I feel like people come to you with all sorts of things. I mean, I didn't really talk about it, which maybe I should. I have a lot of mental health. You get people who have, severe depression, anxiety, schizophrenia, but those are like, I think it's the anxiety and depression that is really sort of commonplace. And, how do you give people advice to sort of like help them cope with, the struggles, especially during COVID. So never a dull day, which is, I think, why I liked it. I found it as a specialist, for example, an endocrinologist, they deal a lot with diabetes and thyroid issues. It's pretty much your whole day, diabetes, thyroid, like almost maybe diabetes. I mean, I enjoy it because I actually really have a really keen interest in diabetes, but I also find it a bit repetitive. So that's my opinion. But I'm sure people who are endocrinologists, they love their job and that's wonderful. But I don't find it repetitive at all. Yeah, so someone's asking just about a day in a family medicine doctor versus a cosmetic, and we're doing both. Mine are just two separate days, right? So I think if you were just doing family medicine, you would just do more of the same thing, which is fair enough. So I think we're about 40 minutes. Do you guys want me to just go over the case really quickly? Yeah. I can just sort of, yeah, okay. Let me just go through and then you guys can ask any questions you have as you want. So my case is Mr. Sunshine. So he's a 50-year-old male, and he basically, he's part of your practice, and he just comes in because he just wants to renew his blood pressure medication. He wants to sort of like come in and leave really quickly. He has to go back to work, and his blood pressure is 150 on 90. So what do you want to ask him, and what would you want to know from the chart? So I don't know if you guys want to like type in answers, or I really don't mind if you guys mute yourself and want to answer any of these questions. If not, I can sort of continue as well too.
So there's just a little bit of a lag onto the YouTube live, so it'll take a minute for.
Got it. Okay.
So we can just hang on a minute. I'm sure there'll be responses.
Yeah, no problem. Yeah, so the question is like, has he been taking his blood pressure medication properly? Great question. Great question to ask. I remember when I was in school, I think I always always avoided answering the questions. I mean, not that I didn't know the answer, just I always I wanted to just like have someone explain it to me. So if any of you guys don't feel shy to answer, I mean, there's probably something you say is probably relevant. If not, I can kind of go on, and if I see something else you guys ask, I'll definitely add it on to what you guys said. So before you actually, answer the question, I think the more important thing is what is high blood pressure, right? So hypertension is the other name for it. So if you think about it, like the blood pressure is basically the pressure that the blood is flowing through your blood vessels. And you usually see it as two numbers, a top number and a bottom number. So the systolic number, which is the top number, is basically the blood pressure, the pressure as it goes when the heart beats, and then the bottom number is basically as the heart relaxes. So that's the systolic, and then when the heart relaxes, that's the diastolic pressure. So in just in terms of like looking at what is actually normal, because to answer the question, you'd have to know, like, is this 150 or not? Is it good or bad, or we don't really know, right? So obviously from this thing, you'd see anything over 140 on 90 would be considered high blood pressure. And so this is from the American Heart Association. So it's interesting, in Canada, we have 140 over 90 as our definition of high blood pressure. And you need to have about 5 readings or so to be diagnosed with high blood pressure, unless you have some really high or elevated high blood pressure like values, then you can be diagnosed sooner than that. But you guys actually, in the States, you guys have this sort of high blood pressure stage 1, which is like anything over 130 on 80. So a little bit of a difference between how you guys do it and we do it. And it's probably just to pick out more people that might be at higher risk. So same question, but what would you sort of want to ask him? So to be able to know what to ask him, so does he check his blood pressure at home? A lot more people now have machines at home. Again, the answer that you guys had, which was like, do you take your medication regularly? A lot of times I'll ask people to bring in their medications with them. A number of times they'll be like, oh yeah, I take the little white pill that you gave me, and I'm confused because they take more than one pill, and I don't know if the white pill they're referring to is the correct white pill. Other things you can ask, we focus obviously a lot on medications, but people often forget that lifestyle stuff, like what kind of stuff they're ingesting. So salt can affect blood pressure. Caffeine can affect the blood pressure more acutely, meaning in a short-term basis. So like if you had caffeine and you check your blood pressure, there's a higher chance that your blood pressure is going to be higher. If he exercises, see if he's gained any weight, has he had any life stressors. So this is what he says. He says that he doesn't take his blood pressure home. He thinks he generally takes his medication, but he misses a couple of times, so you want to know why, right? So that was a good question to ask. Someone's asking if they've gone through a tense situation or had any physical activity that he's not doing. So those exactly right. So a lot of times patients are like, well, what you're trying to figure out is there a way you can help him? So if you're just being lazy, maybe not, but maybe he's a lot of my patients, they work night shifts or different hours, so he just forgets to take it at times. So maybe you can try to change the timing. Can you ask him to put a timer on his watch or his phone so that he can remember something that will help him ensure that he takes blood pressure medications regularly? So he says that he forgets to bring his pills with him when he goes to work. So makes sense. So, see if you can sort of work around that. He says his diet is pretty balanced. Sure. People will say this, but how do you really know, right? His wife likes to cook spicy Jamaican food, so he's Jamaican. So that probably spicy food probably has a lot of salt in it. He has a cup of coffee this morning, and then he came to see you, so that might be what was making his blood pressure high. He doesn't think he's gained any weight. He has a stressful job. He doesn't exercise. So it's very common as like what a lot of my patients have. Sometimes they work 2 jobs, so it's hard to sort of say, well, why don't you go exercise? There's not as much time in the day to be able to do all those things. So interestingly, if when you, like I said, like blood pressure can be sort of affected by so many things. And what you want to do is have an idea of the trend of his blood pressure. So, if he gets anxious every time he comes to the clinic, there are people who have white coat hypertension, meaning that they always have higher values in the clinic. So if you had a machine at home, you'd actually figure out, like, when he's relaxed, what is his blood pressure like, right? So obviously compliance is often a big issue. Compliance just means taking your medications regularly. And so obviously, is the salt playing a big role? Coffee, stress, all that kind of stuff. The other things that you think about are like, what are the risk factors for people having high blood pressure? So people who smoke, people who have diabetes, who are obese, who have high cholesterol, inactivity. Sometimes I have a lot of patients who are actually in relatively good shape, and they just have a very strong family history of high blood pressure. So they get kind of frustrated, like, why are you putting me on a medication when like I exercise? And some of the times it's not really their fault. The same with ethnicities. I have a lot of patients from the Caribbean area, and a lot of people from Africa have a higher predisposition to have higher blood pressure. As you get older, and generally males tend to have more issues with blood pressure. So in terms of like looking at his chart, what you probably want to do is figure out like what his last blood pressure was, right? So let's say in his case, he had, it was like 160 and then over like 92, and then it was like 145 on 85. So you just know that they're still kind of high. Again, you still don't know, is it just that it's always high here, or is it just or is it really that he has high blood pressure? So we're obviously going to look for any risk factors he has. We're going to look to see if he has a family history, see what medications he takes, see when he had his last blood test. So, I mean, we look at his chart and surprise, so like, his blood pressure is like 128 on 78. He's not diabetic. He does smoke. Alcohol, he does take 1 to 2 beers every night. His dad and uncle had high blood pressure. Perindopril is just a blood pressure medication. So he takes that, and his last blood test was over a year ago. So what are you going to do? Does anyone know also, I kind of don't remember, I don't know actually the answer to this question in the States, but I know the answer here, which is how many drinks of alcohol would you consider to be normal for him, for a male? Like, is that like 1, 2 beers, is that kind of okay or not? Give you guys a couple of seconds. So questions would be, what's the normal amount of alcohol that would be considered okay to have at night? And sort of like, what would you do knowing sort of this information? So blood pressure is, lower before, higher now. Four. I think I'm assuming you're talking about the beer. So I'll wait to see if anyone else has another answer for anything else. Oh, it's okay. Don't worry about the wrong answers. I mean, I'm pretty sure like when I was doing stuff, I didn't know any of the right answers. All good. Or it is just a learning process. So I'll give you one, and I'll wait to see if anyone has anything else to say. So actually, the recommendations are up to 2 beers or 2 alcoholic drinks a night. And what you want to make sure is a standard alcoholic drink, so not like a alcoholic drink that's like, that big kind of thing. So, technically if you had like 10 to 14 beers a week, it would be on the upper limit of normal. I have people who take like 6 to 8 beers a day. So, for sure that that's an issue. So I'll move on and just see if you guys want to add anything, you definitely can. So yeah, the thing that you want to do is, you notice his blood pressure was kind of on normal before. So I sometimes will get people to repeat their blood pressure in the clinic. In fact, what we often have started to do in our clinic is to do what they call a BP True. It's a machine that actually checks the blood pressure and does like 3 or 6 readings, and then it averages it out. Because what happens is if you come and you do one blood pressure reading, it can often be elevated, but as you sort of sit there and you relax, you'll find that a lot of people's blood pressure will actually come down. So let's say, it comes down, it's 145 on 85. You check his heart and his lungs, everything looks okay. And, you're checking his height and his weight, and his body mass index is 27. So he's a little bit overweight. What do you guys want to do? Are we worried, not worried? Waiting. That's a great question. Great answer. Ask him if he wants to consider consulting a nutrition. That's a great answer. Because, at the end of the day, a lot of people, like, again, and a lot of doctors, I'm sure too, we focus a lot on medications because, to be honest, that's a lot of what we are taught. But you'd be surprised. I mean, I've been surprised at a lot of times, even with blood pressure, even people who have high sugars or diabetes, how much actually, seeing a nutritionist or a dietitian and also altering habits can really make a difference. Someone was said that they were worried and maybe to put him on a different medication to help control the blood pressure a bit better. Yeah, I mean, we definitely know his blood pressure is high. And so we definitely got to do something about it. So this is sort of like, this is an overall, so this is when you talk about being more preventative and just sort of more inclusive instead of just, putting him on medication. There's a couple of things we can talk about. So one thing you would tell him is that, yes, your blood pressure is elevated. Technically we should talk to every patient who smokes about considering quitting smoking. Though it doesn't sound like a huge statistic, but they say about 4% of people, if their family doctor talks to them about quitting smoking, will actually quit smoking. So, I mean, it sounds kind of a low number, but at the same time, it's 4% more than, otherwise. So just the fact that you're able to communicate with people and they have a trusting relationship with you is pretty cool. One thing we know is that he hasn't been taking his blood pressure medication every day as well too, right? So the question is, is his blood pressure a little bit high because he's just not taking it every day? Which might be part of the problem. I agree with him seeing a dietitian. You'd be surprised that, what's nice about a dietitian, which is harder for me as a family doctor, is I don't have an hour to sit down with someone and review what they eat. So they literally will sit you down and say, like, what do you have for breakfast? What do you have for lunch? What do you have for dinner? And then what do you have for snacks? And they also can tailor it based on your ethnicity, which is kind of cool. So like, in certain cultures, you'll eat certain types of food, right? So it's very, they're more specific towards that person. So see if you can come up with a way for him to exercise and maybe reduce stress. May or may not be able to do this, just given his schedule, but maybe he can start, even walking maybe 10 minutes a day and maybe write up a prescription for an exercise regimen. He hasn't done a blood test for over a year, so probably a good idea to check things out. In specific, anyone who has high blood pressure, you want to check out their kidneys and see, their kidney function. And you say, well, you know what, and that suggestion about trying on a different medication is a great tip as well too. I purposely, there's not anything you would know, but I purposely picked a medication which is like a medium dose of it, so he can definitely increase that dose, which is the same effect, which is that he needs to be on something a bit stronger. So this is very common for my patients. Well, doc, why do I have to worry about my blood pressure, right? Like, in fact, I actually feel fine. Like, why don't you just stop my medications? Okay, this is also very common. So you're talking to him, you're on a different page. He wants to stop his medications, and that he needs to at least be on this, / maybe even do more. So how do you talk to people about this when you guys are in different pages? So this is the kind of stuff that people don't talk a lot about in family medicine or just in medicine, which is, we're taught like, you have high blood pressure, so you increase the medication, tell them to go see a dietitian, you tell them to lose weight, you tell them to reduce salt. But, what they don't tell you is that the person on the other hand is actually a person, and they may or may not agree with what you say. And so how do you deal with that? That's the bigger question. So, there's different approaches. I think in the past, people would say, take the medication or don't. That's, essentially like, tell the patient you're going to write out the prescription and don't give them a choice, but are they going to take that medication? Yeah. Someone wrote about like talking to educate the patient and talk to them what the actual consequences are. Absolutely. Give him examples of what can happen. Exactly. Give him facts of what might scare him. And sometimes it works and sometimes it doesn't, but you're absolutely right. So definitely talk to the patient about what high blood pressure is. Talk to them that, a high proportion of people will have high blood pressure, don't even know it. And you have a higher risk of heart attacks and strokes. And not only that, you can have issues with kidney failure. A lot of people don't know this, but you can actually have sexual dysfunction, heart failure, vision changes. It's interesting. Out of all these things, the heart attacks and strokes kind of scare people. But I'll be honest, anytime, I don't know, for my patients, anytime you tell them their kidneys are going to run into a problem, that for some reason scares them the most. Yeah, good question. But how do you talk to a patient who doesn't always listen? Yeah, and again, I'll try to end this case. I'll kind of talk about that. But the great question, because that's actually sort of the learning lesson I wanted to sort of go through. So yeah, for some reason, my patients get afraid about anything happening to their kidneys. So that seems to be the bigger worry about them. So he sort of says, okay, listen, doc, I kind of see what you're saying. I will take my medication. I will see a dietitian. Be honest, I don't think I'm going to quit smoking. And what I think is the best is that if you can have a really open, honest relationship with your patient and have this relationship where, they can be honest with you, right? So it sucks that yes, he's not quitting smoking, but at least he's honest with you. He's telling you, listen, I don't think I'm going to quit smoking till we talk next. So at least you know that. And you say, you know what, I respect that. Maybe we can talk about it again later. No problem. He agrees to do the blood test. He'll think about exercising. So he's sort of like, I don't know if I'll be able to do that. And you ask him to increase his medication, but he says, listen, I would rather do all the other things that you say. And then you basically agree to follow up in 2 months. And he's going to buy a blood pressure machine and, check his numbers at home. So that's sort of like the end, but basically it is just the case was just to kind of show you that, we talk a lot about the medical aspect, but these are real people, right? So they have opinions too. So you have to actually, what I feel like they don't teach you is you have to learn to sort of like manage what people's expectations are. So, I think in the end, a lot of times I will do a lot of give and take, and I feel like it works really well for my patients. This patient ended up coming back, and to be fair, if you kind of give someone a warning like, hey, if your blood pressure isn't high in the next 2 months, then I will probably increase your blood pressure medication. They actually take that pretty well. You'd be surprised, because you give them the encouragement and you give them the drive to want to make changes. And so a lot of times if they aren't able to achieve that, they're often agreeable. I feel like a lot of people want to just be empowered with their health, and they don't want to just be stuck on medications or not given the chance to make any sort of changes on their own. So in terms of, the last question, which is how do you help people who don't want to listen? The reality is your job as a doctor is not actually to convince someone to do anything. Your job is to educate them and to tell them, based on recommendations and your opinion, what would be the best course, and explain to them what would happen if they didn't follow that course. And I have patients who have awful blood pressures, really high. Same with the patient I mentioned who had high sugar values. All you can do is document, and you just say, discuss with patient, these are the risks, patient aware, we'll follow up again. And you just try your best to sort of like convince them every time, and you win some battles and you lose some battles. And I think that was one of the harder lessons for me, is that I'm a doctor, I'm supposed to help people. And you realize that at the end that you can only, help people as much as they want to help themselves. So but I think I will leave it at that. I don't know if you guys have any questions or anything like that. It's really far back, but I can leave my information here. So I have done quite a few of these presentations, and you guys are more than welcome to email me if, I know that I often didn't feel as comfortable asking questions, like I said, in forums. So you're more than welcome to email me. And also you're more than welcome to follow me on Instagram or ask me a question there as well too. It's not a problem.
Yep. Thank you so much, Dr. Ramzan.
You're welcome.
A great presentation. The case study was amazing too. Definitely learned a lot from there as well. Thank you so much. And for everyone who's still there, the link to the Google Forms was just posted. It'll close at 8:35. So be sure to get that done. And yeah, thank you so much.
You're welcome. Hope you guys have a good rest of the day. Stay safe. And if you need anything, I'm more than happy to help you guys out through anything.
Thank you so much.
Okay. Have a great day.